and engineering. I'm actually in a school of environment and technology in a faculty of science and engineering. So I'm very much from a multidisciplinary background. I'm a graduate in microbiology, but I've worked throughout my life with sanitation experts in water supply and sanitation. And why am I here? Well, I'm here with a fair degree of humility. I've got an awful lot to learn still, I appreciate. I started out my career about 20 years ago with an interest in less economically developed countries, in sanitation for poor communities. I did some interesting work 20 years ago in Brazil on a low-cost sanitation system. So I did that, ended up in Brighton. There wasn't a great call for pit latrines in Brighton, and I realised I had to change a few things. And I thought, well, follow the money in a way, quite cynically. People seem very concerned about bathing waters, and in recent years we've done very good work, I think, on developing methods for distinguishing where the pollution's coming from on Brighton Beach when we do have contaminated bathing water. It's quite interesting from a microbiological perspective. However, I can't get that concerned, frankly, about a few middle-class surfers getting a little bit sick for 48 hours. When you think about the burden of health disease around the world, you know, it's not the thing that drives me. So, very recently, from just of luck more than anything, I've ended up doing some interesting work in less economically developed countries. Last year's conference was it Talking Global Health? This one is Doing Global Health. Maybe next year we can do Thinking Global Health, and I'm not sure if that's in the right order. So that, try not to talk to me. I've certainly been doing global health in the last year or so. I'm very glad to be here to pick your brains and start thinking global health. I must not talk too much. We've got 20 minutes and I'm sharing this. I'm very happy to share this session with my friend and colleague Sharon Long from the University of Wisconsin-Madison. And we've met over a number of years and we've realised that we've got some very shared interests. And she's over in the UK. We're hoping to collaborate. We met last at a meeting in New Zealand where we were asked to contribute to a day on water and sanitation following what had been learned following the Christchurch earthquake. And what I learned from that was a very different scenario to my experience last year in Haiti. So obviously an economic difference, a very big difference in the reaction. So, bottom line, am I telling my grandmother how to suck eggs? You know that, hopefully, that waterborne disease is still a big issue. It's still an important issue in Europe, but in the 4/5 of the world, that we might call the developing world, it's still a massive issue. And people from my field tend to be a little bit chippy talking to physicians, like you don't understand how important this is. But that's unfair. In a recent survey in the Lancet, readers were asked what is the greatest breakthrough in health in the last 100 years. And it was the toilet, it was sanitation. So I must realise that even medics understand that this is important. Moving on. Those headlines are always about mortality, about infant death. I mean, it's shocking and it's awful and it does get attention. But it's not just about mortality, it's about morbidity as well and the impact of not having sufficient water supply and sanitation. Last year, I also worked in Malawi with UNICEF, and I don't have a chance today to talk about that in detail, looking at water supplies in villages and how we can develop better pump design and better community structures in order to guarantee clean water. But if you're living with chronic diarrhea within the first 5 years of life, it is going to affect your development, your growth. It's not just about height, it's about mental development, etc. So, I call myself a microbial ecologist, and I guess this is the black box that I live in. My interest, my specialism, is how pathogens behave in the environment. But increasingly I'm realising that just talking to ourselves inside this black box is getting us nowhere. That disease happens when microbial ecology, infectious disease happens when microbial ecology crashes with human ecology. And in a disaster setting that happens in very different ways to the run-of-the-mill sorts of diseases. There's an idea of syndemics, that in close proximity diseases work together. There's an interaction between the different diseases. So it's very complex, and I don't understand it, frankly. At this point, I'll pass over to somebody who does understand more. Sharon's going to give a US perspective. I'll leave it to you to...
Yeah. So this is the perspective is a little different than what you've been hearing from all the other speakers yet this morning. But where my interest comes in is, very similar to Huw. I started out in life wanting to do all kinds of altruistic things, work in poorer countries and developing communities. And really my job now, so I have two jobs. I'm a professor at the university, but I also work for the state of Wisconsin for their public health lab and their environmental health division. And I call it making strides to infinitesimally improve the life of entitled people in the state of Wisconsin. But hopefully, what I can do in working with Huw and some others in this community is take some of those lessons and processes of how we do that, translate them to a more grassroots level, and get some real work and real revolutionary change done. Okay, so I want to talk about the 1993 Cryptosporidium outbreak in Milwaukee, Wisconsin. And I would say this is the largest waterborne disease outbreak documented in North America and perhaps in the industrialized world in recent times. So what happened was we had, technically we had this perfect storm of events. So it was early spring, we're a farming state. The farmers were anxious to get the manure that they've overwintered onto the fields, get the fields prepared for planting. So it was early March. Now, if you have ever been to the upper Midwest, you know that the winters, we can have thaws and then it can snow again and everything would freeze. So what happened was after the farmers had gotten a lot of this manure out on the fields, we had 14 centimeters of rainfall in approximately 30 hours. Just a lot of rain. Our typical storms are probably on more of the order of 1.5 centimeters. So this is quite a bit of rain. And what happened was at the Milwaukee Waterworks, so they did have a water treatment plant, but they saw that the typical Lake Michigan turbidity went from 3 to 4 NTUs up to 44. So the water now was visibly cloudy. Okay. And typically their monitoring for coliforms are an indicator of bacterial health is usually less than 20. It's very, very nice water, very clean lake normally. And it went up, again, several orders of magnitude up to 3,200, okay? And so what happened was all of this contamination coming into the water plant overwhelmed the treatment processes. And so I educate engineers and I tell them that it is not if your engineering solution fails, it's when your engineering solution fails, okay? So, and they had a lot of difficulty. Coagulant is a chemical they use to bind up all the particles to get them to settle out and filter out, and they were unable to do that properly. So how did this come to the attention of the public health community? Well, within the states, there are generally regional health departments. So the Milwaukee Health Department is in charge of Milwaukee County, which encompasses the city of Milwaukee and a number of its suburbs. And they reported to the Wisconsin Department of Health, who I report to, and they said, we suddenly have widespread absences in hospital workers and in schools. So when your hospitals are understaffed to operate properly, this gets noticed. Okay? When your classrooms and you're calling for substitute teachers and there's no substitute teachers, this gets noticed. Okay? And so in part of the investigation, they looked and they said, yes, we think there may be a waterborne cause to this outbreak. In the beginning of April, so the rains came in the beginning of March, and in the beginning of April, we actually were able to finally see what happened. And so of 2,300 stool samples, the clinical community, we looked at them and we said, our usual suspects, pretty low, okay, that only 1 of 20, 2 of 10, things like that. So these are probably not our suspects. So we go further afield, and we looked at some possible others, enteric viruses, Yersinia, Aeromonas, again, really low percentages. These are sort of the levels that are endemic in any large population. So what is going on? Well, at the time, we didn't routinely test for Cryptosporidium, but someone sat down with all the onset symptoms and whatnot, and said, perhaps we should look. And suddenly, you see, 29% of the samples that were tested that were collected between March 1st and April 6th, 29% were positive for Cryptosporidium. So then in the second group of stool samples that we had from April 8th to April 16th, and lo and behold, again, about a third. Okay. So based on that, we conducted a telephone survey, and of the people that picked up the phone, and we asked them about having incidences of diarrheal disease in their homes, approximately 50% of the people that picked up the phone told us, yes, we have had, incidents within my family and within my household. Okay? And so the Public Health Service and CDC was brought in. It's estimated that 403,000 people got sick, and unfortunately, approximately about 100 people died of complications from the Cryptosporidium. So we vowed never again. So Wisconsin made a big investment, and I'm not saying that other communities in the world can make this kind of investment, but I just want to go through a couple of the organizations and frameworks that we have to make sure it never happens again. So the first is a voluntary mutual aid response network between the water and wastewater agencies, which tend to be public agencies in the United States. And the idea is that these people, all the superintendents, all the operators, they get together twice a year and they know each other. So it's sort of a community-based, and they establish agreements if your utility and your city is affected by one of these disasters listed here. We will, ahead of time, agree to help you as long as our city or our county is not affected. And these agreements are made between people who know each other now. We bring the community together. So you're helping someone you know as opposed to a faceless community. And it makes it very, very effective. We had some floods in 2008 where this network was called upon, and it was really, really helpful. Okay. We also have the Health Alert Network, which I am part of. Every person that works in one of these entities, when they start, they're given a little magnet put on the refrigerator with phone numbers and websites where you can access information about where there are outbreaks and epidemics going on within the state. And some of the key players, EMS, law enforcement, respond to these kinds of things. Okay? And then we also have the statewide Wisconsin Emergency Response Plan. Again, bringing together people from very different parts of the community, all supporting the public health. And so I want to leave you thinking about how do we bring those communities together, and we'll discuss that more this afternoon.
Thank you very much, Sharon. My apologies if you're living with epilepsy, because I'm going to be flicking through a lot of quick slides, I think, quickly now. So I think there's lessons for me to learn from the United States, and then I think about, from my experience in developing countries, what is applicable and what's not, and it becomes much, much more complex than a naive microbiologist can deal with. This is the experience I had last year of playing the hero in a way and working with an NGO in an emergency situation. And I think we did some useful work, but it also raised a lot more questions for me about what we're doing and what's right to do in these situations. I said I worked in Brazil about 20 years ago. I published this paper, which sort of disappeared without a trace. I occasionally look on Web of Science, and I'm underwhelmed by the citation rate. And then suddenly I get a call from Médecins Sans Frontières saying, "We've read your paper, wow." And I was chuffed to bits, and I started giving them advice on the phone. And then naively I said, "If you'd like me to fly out to Haiti, I'm more than welcome to do that. Happy to do that." They said, "Right, we bought your tickets, meet you at JFK on Sunday night." And I went out for 2 weeks, and it was an amazing experience. So it's a technology project. It's about treating wastewater in emergency situations where you can't build a great big biological treatment system. And the thing you need to do is to disinfect a hospital wastewater very quickly. But chlorination's not going to work. You're not going to chlorinate gallons and gallons and gallons of water. You have to find a cheap alternative. You've seen one of these world maps before, but Haiti, which disappears on a normal map, becomes enlarged because this is about lack of access to clean drinking water and sanitation. So this is Haiti. The US disappears, Western Europe disappears. So it's already a big problem in 2010. So that explains what it is. Sorry to rush. there was an earthquake. You'll be aware of this in 2010. The numbers killed, what's quite shocking is that we don't know. In Christchurch, you know how many hundreds of people died. In Haiti, there's absolutely no idea, because there's not the infrastructure to have a proper census of who died. So, and these are just estimates, and these numbers, not to confuse the two issues, 10 months later, a cholera epidemic. I don't have time today to talk about where that might have come from. The prime hypothesis, of course, is that the UN soldiers from Nepal and poor sanitation system caused the outbreak. But there are alternative hypotheses available. So, CTC is a cholera treatment centre. Médecins Sans Frontières do marvellous work in these situations. In the cholera outbreak, if you can get in the centre and be rehydrated within 48 hours, you should survive. People shouldn't die from this disease. So these CTCs are doing very good work. But what they do is also concentrate the pathogen. And if you're living downstream, you don't want to be downstream from a cholera treatment centre unless they've got adequate water supply sanitation system there. So I was there for 2 weeks, got out a little bit, took a few photographs. Water is being tankered in. There's no infrastructure, clean water. Construction industry is doing very well after the earthquake. Collapsed buildings around the CTC. When I went into town, the middle of town, the situation was so awful, I put my camera away. The cathedrals collapsed. People are living on the rubble. They've been there for a year. They'll be there for years to come. Absolutely appalling situation. The Cholera Treatment Centre is producing highly packed, wastewater packed with pathogens, and normally infiltrated into the ground in the situation, but the groundwater was so high they couldn't do that. We had to think of an alternative. Other NGOs, and I should say not Médecins Sans Frontières, were tankering it to what they call a controlled landfill site. Well, that's the controlled landfill site. And these are people living on the controlled landfill site. This is tankers of cholera waste going to their neighbourhood. So Médecins Sans Frontières, Holland at least, were not doing that, but others in desperation were. And it's not a solution. That's a cholera treatment centre. And this is us trying to do research in an emergency situation with, that's supposed to be lime. It doesn't look like it to me, so that made things difficult. It's glamorous work, carrying around buckets of cholera stools. And that is the lab that I constructed from what I'd taken over in my suitcase. Rats crawling over your feet, and lots of regrets about the equipment I should have taken with a bit of hindsight. So we did, under a very difficult situation, we produced a system. This is anecdotal, not very good, strong evidence. This is the wastewater final leaving our treatment system. This is counting E. coli, an indicator of fecal pollution. That's the final, what comes out of our treatment system. This was upstream. This is what was running in the stream through an urban stream. Basically sewage was coming downstream. So in a way we were diluting the river. The treatment system was working well. I won't talk about the technology today. If you're interested, we can talk this afternoon. And it was effective. But it raised a lot of questions for me. And I was reminded of this photograph I saw in New Internationalist a few years ago. And I got in touch with the cartoonist, got permission for once to show the cartoon. I mean, when I saw that years ago, I thought, oh, I'd never be involved in that sort of thing. And there I am, being an expert flying in. Somebody this morning asked a question about donor dependency. And I thought, wow, yeah, I am in this situation. And also in Malawi, working with UNICEF, okay, that time in collaboration with the University of Malawi, but in an ideal world, it should be the Malawian government getting the University of Malawi, getting trained people to do that. Maybe my role is more in education, in that we should be collaborating with African universities and collaborative courses, and actually building up the trained people in Africa. Because bringing them over here is increasingly difficult. It doesn't help the UK border agency stopping them coming in. So, rushed, I'm sorry, over-enthusiasm, I'm stopping. These are the questions we thought we might raise this afternoon if you come to our session. But we're here to listen and plagiarise your ideas. Thanks a lot.